Good afternoon, Santa Clarita. This is Tom Burton, the Orthopedic Program Manager here with the Providence Holy Cross Health Hour, coming to you from KHTS, your hometown station, and can't be any more excited, be able to leave the hospital, no offense to the hospital, but to actually be able to drive up here when it isn't actually on fire or scorching hot. So, beautiful day. Everyone who might be listening, please take advantage of this because I hear the heat's coming back. But certainly glad because we've got a room full if you're watching on Facebook Live. If not, you can always pick us up off of the KHTS app. That's the nice part is you can actually pick us up anywhere in the world as long as you're on that app. So if you happen to be traveling outside of Santa Clarita, give you the opportunity to be able to see us. And special thanks, of course, always to Justin who mans the board and takes extremely good care of us. Holy Cross, hey, 377 bed hospital. We are very busy right now. I think school goes back into session, and all of a sudden we start getting really busy. And who knows what will happen with the eclipse, because we certainly do birth a lot of children as well. Level 2 Trauma Center, and we are Santa Clarita adjacent. We are also the provider of care for about 30% of the Santa Clarita Valley coming into Holy Cross, and about 30% of our employees are actually living here in the Santa Clarita area, and can't be any prouder with the fact that we have had the opportunity to be able to expand coming out into Santa Clarita. You'll find us over on the corner of McBean and Valencia. Our PMI, our Providence Medical Institute is growing, bringing neurosurgery and GI specialists out into the Santa Clarita Valley. And we're also really lucky, too, that with our association relationship now with City of Hope, where we're actually being able to bring basically state-of-the-art oncology care to the Santa Clarita and to the San Fernando Valleys as well, that normally you'd have to actually go to Duarte. So we're really pleased. We're growing. We are anxious to be able to be the choice for Santa Clarita and all of the San Fernando Valley. And it is really our hope that really we don't ever want to have to actually see you. So we want everyone to stay very healthy. And we've been lucky over the last bunch of months where we've been able to have a variety of different experts, clinicians, staff members coming in to be able to kind of bring their swerve, if you will, to the show. And today is no different. We're joined by two different people now. Let me just tell you, we're going to introduce now. Unfortunately, not a Pac-12 school. Dr. Neha Mirchandani, our medical director for our stroke program. I say that only because a lot of our physicians have either had an association or went to a Pac-12 school. But we're happy to have you now that you've come to the correct coast, which has been great. And Sherry Friedrichs. So Dr. Mirchandani, let me just say hi.
Hi. Thank you for having me here.
Absolutely. Now, we, for those of you who stepped away from your radio for about 5 seconds, realized we were just finishing up with the senior hour with Dr. Dorio and Barbara, and glad to be able to just have that quick little chat. But we're going to revisit some of the things that we talked about. We're really going to be talking a lot about strokes, but it's always an interesting question. Okay, and we're going to come to you as well, Sherry, who is our stroke coordinator for Providence Holy Cross. And Sherry, you've been at Holy Cross for, we'll get back.
Oh, that's
How long have you been at Holy Cross?
19 years.
19, okay. So we knew each other for a while.
We did.
For a long, long while. So it is kind of like old home week as it goes. But Dr. Mirchandani, why did you get into medicine? What drove you to that first? What was the inkling?
Well, the rest of my family is in finance jobs, so I guess I sort of wanted to do something a little bit different,
A little
something
rebellious.
a little bit more stable. That's probably the one of the reasons, but there's so many. It's such an amazing, vast field. There's so much you can do with it.
Correct. And then you grew up on the East Coast, though.
I did. I grew up in New Jersey.
Okay, and so that's one of the reasons why you kind of stayed on that side,
Right.
And not only but with great schools as well. So,
Right.
but you went into neurology out of just how amazing the central nervous system actually is, and then I noticed that you kind of tended towards the vascular side of neurology. Kind of go into that a little bit.
So I had to do a preliminary year in medicine. So neurology residency is 1 year of a prelim and then 3 years of neurology. And neurology is a very esoteric field. You'll see that if you go to a different neurologist, you might get a totally different opinion.
Right.
Some of the diseases are so complicated and at the same time fascinating. I liked the aspect that stroke kind of gives you an organized sort of algorithm of how to treat the patient. So in some sense, it's like a subset of medicine. And I feel like there actually is a plan with stroke. There actually is something that we can do for these patients. And we have so many advances in the last several years.
Robert Frost actually, he wrote Road Less Traveled, and with stroke before, there was 9,000 different roads that led in a variety of different directions, and that's one of the things that made it so difficult years and years back, but now we are actually finding there is more direction, if you will, that we could map quest our way to being able to get better outcomes.
Right. And I felt that a lot of times I was being, especially in my training, I was being sort of discouraged from going into stroke because a lot of people would say it's boring, there's not much you could do for the patients, it's, just a dry field. But I think that that has changed significantly in the last few years, and I'm extremely happy that I went into it now.
Yeah, and I think the other part of it too is that even the smallest of gains, the reward on that can be tremendous, and that it takes a while. You actually have to work towards that, but that's okay, and that's okay. And Sherry, now you've recognized. I mean, you've been working with this for quite some time. Tell me one. Now, your background is.
Well, I'm a nurse, and I'm also a nurse practitioner. And I started 8 years ago managing the stroke program, and things have changed tremendously in the last 8 years.
Yeah.
So,
And then now, how did you get into the field? You started nursing first, and then went into nurse practitioner.
right. I became a nurse practitioner, family nurse practitioner, and they offered me the job as the stroke coordinator about 8 years ago. And I didn't really know anything about stroke, but it was kind of a new emerging role within the hospital to develop primary stroke centers and comprehensive stroke centers. So I accepted the position thinking I would give it a try, and then I realized that I needed more specialty education. So I did a 2-year advanced practice nurse stroke fellowship, and then I went on to get my doctorate, and I did a project for stroke. So I've learned a lot, and I learn every day.
It amazes me every day that I get the chance to go to work because I'm going to say this, and I mean it in a very positive way, but I get a chance to really encounter an awful lot of studs. You guys are studs, studettes, I guess. With a tremendous amount of knowledge, and I think that's probably one of the biggest reasons why we are noticing much greater success for our stroke patients that are coming in. Would you agree?
Yeah, our stroke patients do.
They do.
excellent.
They do amazing. And it's amazing to just watch that process just in a few days.
That is great. And we talked about earlier on the other show with the senior hour that we are actually going for our comprehensive designation as a program. We are already a center of excellence, but we want more. All right, it's the American way. We want more.
Right.
So
And the guidelines are changing, and the stroke guidelines have changed in the last couple of years, and we need to provide the best services we can.
that is great. And then I know you're taking a very strong role in getting that comprehensive designation.
We're working diligently, very hard every day to get there.
It's a lot of work.
It's a lot of work.
It's a lot of work, and for anyone to understand it, it's that it's not just the medications that's being given. It's
Right.
everything from recognition. In fact, even pre-recognition, because there's going to be a community aspect of it. There's an education aspect, and where prevention has to be a portion of that, I'm sure. All the way going through to the emergency room visit, all the way to the care, the imaging, every piece, nuts, soup to nuts, I guess some people say, that all of that has to be covered within this comprehensive piece, and it's a lot of work. It's a lot of work. It's a lot of work for both of you
It's
guys.
a lot of work, but Sherry's doing an amazing job.
So I as the medical director for stroke, new medical director,
Yeah.
congratulations.
Thank you.
As of July or so, so you're still kind of getting the feet wet
Right.
within that role. What have you noticed so far?
So Sherry and I will do rounds with a team. We have like a multidisciplinary team set up with speech therapists, physical therapists, occupational therapists. We have the pharmacist that's there. We have the rehab director that comes and joins us, and we also have like spiritual like ministry also available. And I think that it's so nice to have that team. We go over some of the stroke cases at least twice a week. And I think that it's just amazing that we have this team set up to do that. And we review all of the stroke cases that come into the ER that get the TPA, the magic blood thinner that you're supposed to get when you come to the hospital within the right time. We review all those cases and we look at fault and we look at what can we do to make this better? What can we do to improve quality of care? And that's what we've been sort of working on for the last month and a half or so.
Well, and for those who are listening, I think it's something important to kind of realize is that in certain areas, maybe with acute rehab back in the day, we would have care rounds where you would meet regularly, where you would discuss, where you'd have this multidiscipline group that would sit down and discuss each patient that was presently being seen in the acute rehab forum. Holy Cross has taken it a little bit further. We're actually doing interdisciplinary care rounds for all of the wings of the hospital.
Right.
So you guys are handling things going on with on the neuro side of it, and probably what 3A and 3B would be my guess, as well as some of the other
And we
areas.
actually do some ICU rounds as well. We
Excellent.
have quite a few patients in the ICU. As soon as they get the blood thinner, they're admitted to the ICU for 24 hours for close monitoring,
Right.
and even longer if they happen to be unstable for any reason.
Yeah, I for those who are listening, it's important to know that the communication within the hospital, not always the easiest thing. However, by doing these care rounds, and we're doing them on a daily basis on all the floors, that gives us the opportunity to be able to have a very large group of people being able to present a person's case. And what we're really recognizing is that we're actually being able to intervene quicker if there are any issues. We're able to demonstrate progress sooner. We're actually able to help patients be able to move on to that next level of care without delay, which didn't always used to happen before, where you'd have patients maybe just kind of sitting there for a day or two, and then eventually things would kind of move along. And so we're a little bit more expedient, which is really good because hospitals really aren't the healthiest places to be if you don't have to be there.
Right. We try to make sure that our patients don't have to stay any longer than they need to, because of course the rate of infection and the bill too. Let's be honest. It's about unnecessary, spending all this money for these patients that don't need to be there for the
Correct.
day. But of course, infection rate increases significantly.
And
we really focus on making sure that patients don't need to stay for longer than they need to.
We've had to do that with the total joint program, where our whole goal is for them to be able to go home. We would prefer that they don't have to go off to facilities if it's at all possible. Again, for that exact same reason, is we don't know who they're going to be paired with in the rooms and all.
And we push for acute rehab whenever we can, because I think that obviously that is the most important thing post-stroke. Most of our patients end up with significant disability, and we want to make sure that we can get the ones that need rehab, the right facilities.
Right. Well, now you kind of prepared a few little things here,
Yeah.
and I'm going to go ahead and just take it and run. Okay, so we're going to play a little game of myth, and you guys throw us the fact. Okay. All right. So myth number 1: stroke cannot be prevented.
Well, that's absolutely false. We've been talking about the advances in care over the last 5 or so years, and up to 80% of strokes are preventable. Time is brain, and it's so important to get patients into the hospital as soon as possible, have family members and friends be aware of what the signs and symptoms of stroke are, and call 911 immediately, because we can give the blood thinner. Most patients up to 4.5 hours. The window is actually up to 3 hours. We do have some exceptions, but we can give blood thinners up into 4.5 hours. And with the advancement in endovascular care, intervening on these patients, very similar to how they do cardiac catheterizations, they put a catheter in the groin, and we could take out clots in the brain.
Now it's
Up to 24 hours now, actually.
Up to 24. Oh, that's
yeah,
fantastic.
we've had some advances, and there's been some recent trials that have come out from Europe that are saying one of the trials is called the Dawn trial. We spoke about it in one of our recent meetings, and basically involving patients that wake up with strokes. It's called dawn because they wake up at dawn and they realize they're paralyzed, they can't speak, but they are candidates for interventional services.
And as you alluded to in the senior hour, we're actually really hot and heavy working on trying to get those interventionists in with the hospital so that we can actually progress into that portion of care, so we can be even timelier with the most state-of-the-art type of treatments.
Right.
All right.
We're actively interviewing right now, so we can hopefully have a full team available to take care of these patients and to provide these interventions hopefully by the first of the year.
It's fantastic. So those who are planning on having a stroke, just wait a little bit longer. We're gonna.
But we still have a plan
Yes.
for emergent services where
Correct.
we can still provide those services and transfer them out to the appropriate center.
That's perfect. That's perfect. Now, you'd mentioned clot. Now, strokes can be clot or it can be due to a bleed.
Right.
But one is more common than the
Right.
other.
We have two different kinds of strokes. One is an ischemic stroke, where you have a lack of blood flow. The other one is a hemorrhagic stroke, but ischemic strokes are more common than hemorrhagic strokes.
Gotcha.
And hemorrhagic stroke basically means a bleed in the brain, and they can be several reasons for that. If someone has an underlying aneurysm, a vascular malformation, also known as an AVM, or an arteriovenous malformation, that may be a reason. Or we have also something in elderly patients called cerebral amyloid angiopathy, where they have deposits in the blood vessels that make them more susceptible to bleeding.
Gotcha.
So these are just a few of the reasons to have a hemorrhagic stroke. There's many more, of course.
Okay. All right. Let's see. Myth number 2. Let's say there is no treatment for stroke.
Right. And we just kind of talked about that there are treatments for stroke now. And regardless of when it happens, you should come in immediately. And I think that's the key feature that we're trying to emphasize, that getting into the hospital immediately is the most important thing, because there could be treatment.
Well, and as Barbara alluded to in the previous hour, her ability to recognize the nystagmus that her husband was suffering with
Right.
Immediately allowed him to be able to get immediate care, which is great. But, recognition is going to be a very big deal, and we'll just kind of skip all over. Tell me about some of the more simple pieces that we could actually look for. I think you had an acronym for
Right. So FAST is one of the acronyms. F stands for face. You ask the patient to smile. You see if one part of the face is drooping. The A is for arms. You have them put their arms up and see if there's any drift in the arms. S is for speech. You start to see if there's any slurred speech or any difficulty just getting the words out in general, like speaking gibberish. And T for time. It's important to call 911 immediately.
that. Okay.
And can I add something,
Sure.
if you don't mind? A lot of people use FAST, but recently they've added the BFAST.
BFAST, okay.
So
Okay.
a lot of organizations are adding the B for balance and the E for eyes, if you're having any problems with your vision. Because if we use the FAST, we can catch a lot of the strokes, but by using BFAST, we can catch strokes that come from the posterior part of your circulation as well.
Of course.
Those are probably the most dangerous strokes.
Right.
The ones that come in from the back of the brain. And they can have very variable symptoms, like Sherry mentioned, balance issues, eye issues or nystagmus, problems swallowing, double vision. Those are very dangerous strokes and need to be looked at immediately.
Of course. Okay, so we're doing well here. Let's see. Stroke only affects the elderly. Well, I was just going to ask this earlier, but not
Absolutely
the case.
not true. I did my training out in New York, kind of in an urban city. I was out in the Bronx, and you see so many young people with strokes, kids with strokes,
Right.
patients with like sickle cell or clotting disorders, or rare types of diseases like vasculitis or problems with the blood vessels. All of these patients are susceptible to strokes.
Well, it's one of the DJs used to be here, T-Cats. She coined, I don't know if she coined it or she stole it from somebody, which I borrowed, was the silver tsunami, was the fact that we have a very large population that is moving into the mean age is becoming greater, and because of that, we're going to see a larger group or larger population that could be candidates for people who might suffer from stroke as well. And so there's a certain level of prevention, things that we could do, just generally. And one of them might just be following up with their physicians regularly.
Right. Definitely. And just controlling risk factors. We mentioned in the last show a couple of the risk factors, but the most modifiable risk factor for stroke is hypertension or high blood pressure. Hyperlipidemia or high cholesterol levels can lead to strokes. Obesity, smoking, heavy alcohol abuse. Those are some of the big risk factors. Diabetes, exactly. There's just so many. It's such a long list, but these are the big main factors.
Right, and I think one of the scary pieces too is that I think the estimate was that 1/3 of the population is going to be suffering from one form or another of diabetes somewhere in the near future. Right. We know that childhood obesity is on the rise, where that's actually somewhere sitting around now the 30% mark too, and a lot of the habits that allow for that childhood obesity will follow through into their teenage years and adult years. And those are all common problems where we can have higher cholesterol, we can have high blood pressure issues and diabetes issues. And all of those three things can cause so much vascular damage to a point where a stroke may be imminent.
Right. To the heart and to the brain. A lot of the risk factors are very similar for cardiovascular disease as well.
Right. All right. So let's see. Stroke happens in the heart.
Well, it's very, like I mentioned before, it's very similar. It's sort of like a heart attack of the brain where you stop blood flow. You can also have clots form in the heart. They can also form in the brain. So when I explain what a stroke is to a patient, because I think most people know what a heart attack is, but I would say most people don't know what a stroke is. And I say it's something that's very similar, bit more complicated in my opinion, but very similar, and the risk factors are similar as well.
Somehow, somewhere, the blood supply going to that tissue has been compromised, whether it be because they're bleeding out into it or that it's been blocked. The tissue begins to die.
Right, and we have two big circulations for the brain. One is the anterior circulation that comes from our carotid arteries in the neck, and the posterior circulation, where we have two vessels that run through the neck, the vertebral arteries that make the basilar artery, probably one of the most important arteries in the brain, and that supplies the back. And the brain is sort of like a circle. The circle of Willis is what it's called. It all just kind of compensates, and if one part shuts down, the other part starts working even harder. Right.
And vertebral artery as a physical therapist, that's always a big one for us. We're treating necks on a regular basis. So we want to try to extend them, rotate them. Let's just see if the pupil doesn't blow or if the nystagmus doesn't kick in.
And vertebral artery dissection is one of the biggest causes for stroke in young people.
Right. So I know we're getting ready to come back. We're going to be going to break momentarily. We have you're with the Providence Holy Cross Health Hour here on KHTS. We're very lucky to have two individuals who are heading up our stroke program over at Holy Cross, Dr. Mirchandani and Sherry Friedrich. And I'm Tom Burton, and we're going to be coming back probably in the next few minutes. We're going to go ahead and continue on with myths, and we're going to move into ideas on how we're going to be treating things. What would be the expectation from when they finally first arrive to a point when they're actually in the hospital, and with the goal of being able to discharge home. So you're with us with the Providence Health Hour here on your hometown station, KHTS. We'll be right back.
Daily Imprints is the premier one-stop shop for custom embroidery, screen printing, and promotional products in the Santa Clarita Valley. Owners Joe and Dana have provided KHTS with quality embroidered company shirts for over 3 years. If it's new business cards or promotional products you need to enhance your image, Daily Imprints is the choice for you. Located on Lyons Avenue, stop by or call today, 661-678-0508.
The stress was unbelievable.
Debbie Morris is a changed woman.
A giant boulder's been lifted.
Debbie called Made for You.
I'd finished a day of work.
Professional, residential, and commercial cleaning.
Walk into my house.
Made for You.
It was an absolute pigsty.
Weekly, bi-weekly, monthly, or even one-time seasonal cleaning.
Our mess kept growing.
255-2922.
Even when we weren't home.
255-2922.
Made for You rescued me.
Who says nothing good happens after midnight? Denny's is best known for their breakfast served round the clock, like the Grand Slam. But you can enjoy breakfast, lunch, or dinner in a casual atmosphere 24/7. At Denny's, the lunch and dinner menu has a variety of appetizers, craveable burgers, salads, and entrees, along with the best desserts in town. Wherever you live in Santa Clarita, there's a Denny's close by. If you're pulling an all-nighter or don't feel like cooking, get into Denny's today. Good stuff is happening at Denny's.
The best live theater can be found right here in the Santa Clarita Valley. The Canyon Theater Guild has been entertaining audiences for decades with top-quality musicals and plays. Located in Old Town Newhall, the CTG also offers workshops for the young actor in your family. For more information, call the box office at 799-2702 or go to canyontheater.org.
There's only one Santa Clarita plastic surgeon who is Yale trained and board certified, Dr. Justin Heller.
To be a board certified plastic surgeon like myself, what that truly entails is about 5 to 7 years of honed surgical training in reconstructive, all areas, as well as aesthetic, so which means your facelifts, your breast augmentations, your body contouring, true training, and board certification. In fact, that's the only board certified area that can be achieved in this realm.
Dr. Justin Heller, warm, understanding, always available for guidance because he's local. HellerPlasticSurgery.com.
KHTS. Doctor, give me the news. I've got a bad case of loving you. No pill's gonna kill my ear. I gotta.
Yeah, welcome back, Santa Clarita. This is Tom Burton, Deputy Program Manager with the Providence Holy Cross Medical Center. You're with us here on the Providence Holy Cross Health Hour, and we are joined today. Very lucky to be able to have two people. We normally don't have multiple guests, which is great. Dr. Neha Mirchandani, as well as Sherry Friedrich, who are our stroke gurus over at Providence Holy Cross Medical Center. And we were just chatting about some stroke stuff and what all was going to be coming up, and we were looking at some myths. And one kind of intrigued me because it has changed. This answer has changed. If you were to ask this 5 years ago, 10 years ago, 15 years ago, 20 years ago, the answer would have been different. Okay, so myth: stroke recovery only happens in the first few months after a stroke.
That's definitely false. It's definitely a lifelong process for recovery. We'll probably touch into some of the important details of like post-stroke depression and rehabilitation and some things that do affect the patient's ability to rehabilitate. Right. And I think in general, it is a lifelong recovery process.
And the ability to reroute, so to speak,
Right,
you know,
right.
trying to change the wiring, trying to learn new pathways,
Right.
new ways to be able to key into the same muscle groups or into the same functions that were originally damaged during the initial stroke. Right. We're pretty amazing that way. And this is one of the reasons, too, I think, why it's such a mystery, the brain, and why I think that you were so intrigued with it, is that we're only scratching the surface. Right. And trying to figure out how in the world you're actually going to get all of this to work.
And in terms of rehabilitation, these patients have to try to get back to where they were before. Talking, eating, driving, even working. Correct. Yeah, quality of life is huge. We knew of a gentleman who came through our acute rehab. I won't mention names, but had a significant stroke, had done an amazing job in his rehab, eventually came back and worked as a volunteer at the hospital, as well as in the physical therapy department, and eventually went on back into employment, which has been a blessing for him. And this whole process probably took 15 years. Yeah, that's so challenging, but when you have good support and social support and family and friends and people that are really around you to motivate you, I think that's also one of the most important factors.
It's diligence too. There's a lot of work involved.
Right.
There's a lot of work involved. So I think one of the pieces we kind of step into, because there's 9,000 directions we could probably go with this, is let's just take a look. So first, prevention. All right. So what can someone do to improve their health and decrease their stroke risk?
So as we mentioned, high blood pressure, hypertension is one of the most important risk factors, and we recommend that after someone's had a stroke, we definitely want to keep the blood pressure less than the high number of 140 and the lower number 90, so less than 140 over 90. Generally, patients should follow up with their primary care physician to get routine physicals, get their blood pressure checked, and make sure they don't need to be on any medications. A lot of patients are on blood pressure medications, but the problem is many are uncontrolled, and controlled blood pressure is one of the most important risk factors.
And it could be something as simple as making dietary changes,
Right.
decreasing their salts, getting out and actually continuing with an exercise program.
Sure.
So there's not only just good nutrition, good physician follow through and follow up, also good fitness. All of these things will probably be very, very helpful. Yeah, sure.
Another thing that I like to, when I talk to the patients, when we go over risk factors, what I tell them is the more risk factors you have, the more chance you have of having a stroke. So there are modifiable risk factors, and there are risk factors that are not modifiable. Right. So the ones that you can't change, if it runs in your family, if you've already had a stroke, you can't change that. As we get older, you can't change that. There was a time when they said that more men had strokes than women, but now we're finding that more women have strokes than men. So if you're a woman, so those, and then ethnicity. So African Americans, Hispanics tend to have more strokes than Caucasians, and so you can't change those things. You have to accept them as risk factors. So then when you take those, if you have several of those risk factors, then you look at the risk factors. If you have diabetes, high blood pressure, high cholesterol, if you smoke, if you drink too much, if you're obese, if you don't exercise, and those are the things you can change. So you don't want to have all of those risk factors. So if you've got the ones that you can't change, by all means, you want to go in there and do something about the ones that you can.
Excellent. Yeah, don't worry about the things you can't change. Work on the things you can change.
Right. And I emphasized a lot on blood pressure, but diabetes is also a huge risk factor for stroke. Diabetes does change the vascular anatomy of the brain too, and it's important that patients follow up very well with diet, exercise, and the number that we check in the blood, the hemoglobin A1C, looks at how well someone's controlled their diabetes over the last 3 months. And after someone's had a stroke, it's important to keep that number less than 7%, and that's really hard to do. So sometimes they have to go on insulin and have good follow-up with their primary care or endocrinologist to make sure that their diabetes is under control.
It's not a passive job now. It's very, very active, where you have to be very, very involved, and it's multidisciplinary, multidirectional. It sounds very involved, but now let's just say we've done all of these wonderful things, we've done everything that we can, but somebody recognizes that maybe there's a speech issue, or maybe they're becoming more forgetful, where they're not finding the words, or having a hard time remembering, or maybe calling someone by the wrong name,
right.
Which was not the usual type of a thing. What should occur? Now, a lot of times people won't automatically know to go to the emergency room, but at least follow up with the physician.
Right, and it's important to get a stroke workup for symptoms like that. Neurology is a complicated field. We have migraines, we have seizures, we have so many different types of neurological events that could be going on with a patient. But you want to rule out the emergent issues, and stroke is an emergent neurologic issue.
And then if we do find, so when we were talking about fast before, if we do see a facial droop, if we see, lack of ability for controlling their arms, issues with speech or with swallowing, all of those types of things, if their balance starts to go, we need to to initiate the emergency system and EMS, and we need to get 911 involved. We need to get to the hospital immediately. What should a patient expect when they actually get to the hospital?
So as soon as they get into the hospital, they are triaged as a stroke code, and we have sort of a team that's set up to respond to this patient emergently. We want to make sure we get vital signs and make sure they have good IV access. We want to get them in to the CAT scan immediately because we can give them the blood thinner up to 4.5 hours, but we need to make sure that there's no bleeding in the brain because that would be a contraindication for the blood thinner.
Right.
Where we have it set up right now at Providence, we have a tele system where a teleneurologist will come and evaluate the patient as soon as they come in and help decide if they should or should not get the blood thinner and decide if they need to be transferred for intervention services if there's a large vessel occlusion or a big stroke syndrome that's going on.
Well, that's kind of nice because before it was really a sense of when could the neurologist get to the hospital, which could be hours or more,
or the next day.
Or the next day.
Right.
And then years ago, there was a time where blood thinners were immediately just initiated because the likelihood of it being a clot, and that was an issue when it was actually a bleed. So it's nice to see that the interventions can actually occur in such a quick time frame, and technology is allowing for that.
And they have these mobile stroke units that Sherry knows a little bit more about, but they have these mobile units that they have CAT scanners in the ambulance.
Right.
Really?
UCLA has one right now. I actually have a girlfriend who works on one in Memphis.
Really?
And the team will go out and they'll scan the patient right there in the ambulance, and they have a CT tech on board. They have an advanced practice nurse, and they have the telestroke where the robot where the neurologist will look at the patient, and they will actually give the blood thinner and medication to the patient before they even reach the hospital.
En route. Oh my gosh.
And then, and if the patient has the large vessel occlusion that Dr. Mirchandani spoke of, they'll make sure that that patient is transferred to a facility that has the ability to retrieve that.
To go in and get it.
Right. And EMS are now being trained to know what a large vessel occlusion is or a big stroke is. If someone's eyes are moved directly to one side, they can't speak, or the whole part of the body is paralyzed, we start to think about this possibly being a clot because this is a big syndrome, a big stroke that's happening.
Right. And so, wow, they can even do that. I haven't actually heard that. That's tremendous. So the earlier the intervention, once the recognition of a clot, the earlier that we can intervene with the blood thinner, the better the chance that clot can dissolve, and we can start to restore blood flow to that brain tissue, which will improve its ability to survive. Right. And so now let's just say that they've had the TPA, the blood thinner, and after it's been determined that it's a clot, what happens next? So they're going to be admitted, would be my guess.
Right. So ideally, if we determine they do have a clot, we have special imaging modality that helps us determine that. We do something called a CT angiogram, which is a blood vessel study of the head and the neck, and we give contrast for that, and we could see where the blood vessel is not filling appropriately, and that's where we know where exactly the clot is. And now they have other special imaging modalities that help determine which patients are going to be good candidates for getting these interventions. Because, like I mentioned earlier, when one part of the brain shuts down, the other part starts to work harder. And patients who have something called good collateral flow, or in general, like the collateral basically means that the other part of that brain is working good, it's pumping well, those patients do better with interventions.
And we see that with the heart.
Right.
Where
exactly.
vessels
It's
aren't
very
working
similar.
as well, and so we regrow new vessels
Right.
to be able to supply. It's a
Vascular
supply and demand type of a thing.
is, 20 years behind cardiology. That's what people say. But we're getting there. And it's the similar concept that you can take out a clot if someone has good collateral flow. And the studies, some of the recent studies from Canada have shown that patients that have good collateral flow do better. And if they don't have good collateral flow, then we expect that they won't do as well with these interventions, and they may have a higher risk for hemorrhagic conversion or bleeding in the brain.
Now the collateral, the good collateral flow, could that be a product of more of a chronic type of a condition that's been slowly developing over time, or is that just?
It only happens really when there's a clot, or if there's some rare diseases people can get called moya, where you get some collateral flow when some of the blood vessels shut down and the rest of the brain tries to work a bit harder.
Got it.
But in general, if there is a clot, that's when we start to see the collaterals coming through.
Okay.
And we see that on certain phases of the CT angiogram. And we're working at Providence to get similar type of scan, a perfusion study with our MRI, because the MRI perfusion is another imaging modality that we can use to determine which patients are better candidates for endovascular therapy.
And it's going to, now that with the, and we're also working on getting the endovascular team on board, so that way when those patients are actually recognized, that they can actually go get it, like they would go get a kidney stone in a cystoscopy or something. Okay. So the patient, we've got our imaging, we've determined a clot,
Right.
they've done their blood thinner, we kind of realize that there are no other comorbidities that may or may not need to be cared for,
Right.
and they're going to be transitioned, I guess, into the ICU.
Right. Well, if they do have a clot, then we alert the interventionalist that comes in, and we alert them immediately when we suspect a large vessel occlusion. So there's somebody that's on call 24/7 that's expecting a call if there is a large vessel occlusion, and they'll come in and they do exactly like I mentioned with cardiology, a catheterization. They do groin puncture, and they try to get the clots out.
Okay.
And sometimes we have a patient who is not eligible to receive the clot busting medication, TPA. Maybe they're on blood thinners already, or maybe they just had a surgery and they're at risk for bleeding. So we can do the CT angiogram, and if we can actually see an occlusion in one of those vessels, we won't necessarily give them TPA because it's contraindicated, but we can absolutely go in and retrieve that clot.
Right.
And that's why these services are so amazing, and they've changed the whole world of vascular neurology.
Right on. So they head into the inpatient arena. You mentioned if they have to go on the blood thinner. I think in conversation that they might have to be in the ICU maybe for 24 hours because there's things we have to keep an eye on.
Right. We need to keep the blood pressure down at a certain goal. We need to do frequent neuro checks. We need to make sure that the glucose is under control, and just so that the patient can be watched very closely, because of course there is a risk for bleeding in the brain, especially after the blood thinner. So it's important to keep them in the ICU so they get the best care.
Correct. And then one of the big key aspects of this is going to be in the recovery is going to be bringing in a variety of rehab, speech, OT, and PT to make a determination of where their deficits are and how we're going to address those. Now, about what time during from coming in through the emergency room to a point where maybe rehab would kick in, what would that time frame look like?
So I usually like to wait until the patient's admitted into a bed. I don't want them to get seen in the emergency department. That's not the most ideal place.
Right.
But I put in rehab consults as soon as the patient comes in, and especially if I think they'd be a good candidate for acute rehab where they can tolerate up to 3 hours of activity daily. I try to get acute rehab consults immediately for those patients.
Right.
And there's a lot of literature to support that early mobilization has better outcomes, but we don't want to mobilize them if they're unstable. But as soon as they're stable enough, we want to get the therapy started as quick as possible.
Right.
Right. And we're finding with the early mobilization that's making a huge difference of pretty much every patient that walks through the door, as long as it's deemed
If
as
they're
safe.
in the ICU, I may wait a day or so. Generally, I may wait a day or so if they're in the ICU, but once they get transferred out to our stroke unit, then that's one of the first orders that goes out to rehab.
Yes.
Right. And then it's just a question of trying to bring back some of the deficits, whether it be flaccid versus spastic, which would be determined by the extent of the injury and to where the injury was. But we have medications and things that can assist with the spasticity.
Right.
And we have ways, as a physical therapist, we have ways to trigger people who have flaccidity to where we can maybe get some overflow to allow for a limb to move. That will allow for improved function. And we're seeing more function, more return of function, where patients are actually doing even better. The outcomes are even better. The ability to return back to a quality of life has improved. And a lot of it's because of that early intervention.
Right. And we have several different scales that we're using to help determine where patients are at and how well they're doing. The big one that we use for stroke is a modified Rankin scale, looking at how dependent the patient is.
All right. Well, you're listening to the Providence Holy Cross Health Hour. We're coming up to the wrap up. Coming up in the next few minutes, we're going to be taking a small little break. And you're joining us here on your hometown station, KHTS. We have Sherry Friedrich and Dr. Neham. Oh my gosh,
it's a hard last name.
Mirchandani.
You got it.
Just more coffee is, I think, what's necessary. But we'll be right back with a wrap up.
Drugs or alcohol abuse can tear a family apart. In Santa Clarita, just like everywhere else, it's an epidemic. The Way Out Recovery is here to help. Call them now at 296-4444 or visit them on the web at thewayoutrecoveryscv.com. The Way Out offers outpatient treatment for adolescents, adults, and family members. The Way Out is compassionate, caring, professional, and confidential. You and your family don't have to suffer any longer. Call the Way Out Recovery now, 296-4444, or visit thewayoutrecoveryscv.com and make an appointment. Asking for help is the first step.
With Facey Medical Group, good health is within your reach. Facey Doctors provide Santa Clarita's finest primary and specialist care at 4 convenient Santa Clarita locations. If you're looking for connected and convenient personal care, there's no better choice. Facey accepts most healthcare insurance, including plans offered through Covered California. For more information or to schedule an appointment, call 1-844-MY-FACEY, 1-844-MY-FACEY.
There's a very good reason Gilbertson and LeCornu have been voted Santa Clarita's #1 orthodontist for 8 years in a row.
There's a lot of orthodontists in our community and a lot of really great doctors.
Dr. Megan LeCornu.
Artistically, I like nice big smiles. Those are the smiles that wow people. So in all my treatment planning, I don't do a one-size-fits-all. I look at the patient's facial structure and I match their smile to their facial structure.
Dr. Megan LeCornu of Gilbertson and LeCornu.
Embrace your smile.
EmbraceYourSmile.com.
Do you like to rock across Africa?
Then the wait is over.
Africa Rocks! Africa's Greatest Hits is now available at the San Diego Zoo!
Who could forget 99 red baboons? Or the African-crested porcupine smash hit, I Got Quills to Pay the Bills! Hey, don't get too close.
And the hits keep on coming.
Africa Rocks has all your favorites from 6 different African habitats.
Hungry like a leopard.
Ibex is back.
Harder, better, Fossa stronger.
And a new track from Kendrick Lemur.
Now, Larry.
Yes, Chuck?
A collection of this magnitude, I'd fly to Africa.
Well, don't pack your bags, friend. Africa Rocks is only available right here at the San Diego Zoo.
Wow, that really does rock.
No, it Africa Rocks.
Welcome to Africa Rocks at the San Diego Zoo. Rolling out July 1st. Stay late now through Labor Day at Nighttime Zoo. Presented by your San Diego County Toyota dealers.
Your hometown station. Hometown station. KHTS. Doctor, give me the news. I've got a bad case of loving you.
Welcome back, Santa Clarita, on your hometown station, KHTS. This is Tom Burton from Providence Holy Cross Medical Center, the Providence Holy Cross Health Hour, joined by Dr. Mirchandani and Sherry Friedrich, and we are talking about stroke. All right, and we've kind of gone through a lot of the risk factors. We were on with the senior hour going through and all the different functions that we're trying to add in at Holy Cross specifically to be a comprehensive stroke center and involving a variety of different procedures and the such, and hopefully having that up running in January. But I think one of the bigger pieces too is being able to get out to the community. All right, and that's, education, knowledge, it's powerful, and, granted, this show is a wonderful conduit to be able to get some of this information out there. But Sherry, you had mentioned that you actually speak publicly.
I do. I've actually spoken a couple of times at the Santa Clarita Senior Center and given a lecture. But if anybody has any organizations that they belong to and they would like me to come, I could give a 1-hour lecture. We can talk more specifically about signs and symptoms and what to expect if you're hospitalized, and I would come out and give that lecture for you. And I can also be reached for questions. My office number is 818-496-4206. I'm there Monday through Friday, but I get messages through my cell phone 24 hours a day. So I would just give me a day or so to get back to you, and I will answer your call.
Great. And is there an email they can also maybe send out to? So many tech-savvy people out here nowadays.
Yes, it's Sherry.Friedrich, SHERRI.Friedrich, FRIEDRICH, @providence.org.
Fantastic. And Dr. Mirchandani, how do we find you?
So I might be a little bit tougher to find. No, I'm always available if there's any consults or any stroke issues in the hospital. But unfortunately, right now I'm not set up to see patients outside of the hospital. Excellent. But I do work with another doctor, and they're welcome to consult with him as well. It's Tri-Valley Neurology. That's the office. It's literally located right across the street from the hospital. And I'll give you that office number. It's 818-898-9898. And you can always make an appointment to see Dr. Nayar. That's the other doctor that I work with. And he's happy to see new stroke patients.
Fantastic. And then is there a website or email?
For email, they can contact me directly on my Providence email, and it's neha.mirchandani. May have to spell that out really slow, @providence.org.
Very good. And this is important stuff. We want to be able to, again, prevention is probably going to be the best piece that we could do as far as for the best outcomes when it comes to stroke, and that the healthier we are, the better the chances that we can prevent, but also for improved outcome, improved function, better quality after a stroke. And anytime we have the ability to have experts that we can actually reflect back on to try to do better, that's going to be our best case situation, right?
Definitely. And
go ahead. I'm sorry. One final thing that I want to let everyone know is that if you are having a stroke, please don't deny that and make excuses and say it must be this or it must be that. Because when you are having a stroke, what's happening is 2 million brain cells in your brain are dying every minute that treatment is delayed. So even though we have up to 4.5 hours to give you that clot busting medication, time is of the essence, and you should come to the emergency room right away. Call 911. Get there quickly, let them know what's going on, bring your medications so we know what medications you're on, let us know the exact time that symptoms started, because the sooner we treat you, the better the outcome you're probably going to have.
Right. And I think the slogan for American Heart Association this year, I think it was "Life is Why."
That is.
Life is why, because we want to improve quality of life and prevent devastating strokes and cardiovascular issues. But just to summarize, just briefly, the risk factors. We talked about high blood pressure. We talked about high cholesterol. We talked about diabetes. We did mention smoking, but that's a huge risk factor. We talked about diet, but the Mediterranean diet has been shown to really reduce the risk of stroke and recurrent stroke. We discussed obesity, exercise, and something else we didn't bring up is obstructive sleep apnea. There's been studies that show that really does increase the risk for stroke. So that's, to summarize, the most important preventative risk factors.
Fantastic. And we're right at the top of the hour. Dr. Mirchandani, thank you very much. Sherry, thank you for coming on a week off, and congratulations. I'm Tom Burton, Orthopedic Program Manager with Providence Holy Cross Medical Center. You've joined us with the Providence Holy Cross Health Hour. We look forward to seeing you next month. You're with your hometown station, KHTS. We'll see you in September.